You see, a lot of the time when I do these test calls, a lot of the time I'm the problem.
Really?
Yeah. Last week I accused Johnny of all sorts of things, and my volume was turned right down.
It's a learning process, right?
Oh, I love it. Hello, Robert.
Good morning.
Morning. How are you?
Yeah, very good.
I didn't know you were into spine clinic.
No, but it never hurts, right? A little bit of extra knowledge.
Well,
Right.
it does hurt, but anyway.
It does.
Yeah, I know. I don't do spines in the Netherlands, so I don't know much about it. So I think it's good to obtain some knowledge while I can.
Thanks for doing this, Fady. I thought it was Johnny Ward doing it.
Johnny Ward did it last week.
No, but I thought he was doing another one. So I just found out that Fady was doing this morning, and I said, "Oh man, it would be great if we can do some critical care CBDs for CCT in October."
Okay,
so
but
thanks, Fady. I know it's last minute.
that's not in this session. That's another session that Fady's going to do for us. In fact, Fady's got like a whole series coming.
Fady's got a series. All right. Yeah.
Oh, Johnny Ward is here. Johnny Ward is here to learn about.
Oh God, Johnny Ward outside. Oh no, it's not outside. It's his window. Oh man, what an amazing house.
Johnny, be careful. Anyone who attends this session will end up doing spine clinics, all right?
Oh, I see. This is the trade-off. Yes, okay, I get it.
The last slide are the dates available, and everyone will be asked to sign up. All right. How are you guys? All good?
Great.
So today I'm going to talk to you about how to survive spine clinics, right? And I'm sure you've gathered by now who is in that picture going through the ring of fire.
David, isn't it?
Yeah, exactly right. It's the little hat as well.
From the army days.
Oh, that's right.
So why did the spine clinic become a problem? Like it's a code that we cannot decipher it, or registrars find it very, very frustrating. So I have a few reasons in mind, and then everyone I'm happy for everyone to chip in if they find other problems with this clinic. So number one, I feel that this clinic is filled with non-specific lower back pain patients, which can be challenging because you basically don't know what to do to them. Also, they are not the easiest cohort of patients to deal with, shall I say. And thirdly, what we find is that we are not sure what the consultants are looking for all the time. All right? There are too many patients to see in a very short period of time. And you don't know what to do with specific cases. Like, for example, you see a patient with a spinal deformity. Okay, what's next? You see a patient who had injections that didn't work. What's next? So it's not clear. So what I'm going to do is I'm going to give you an overview and some keys on how to deal with spine patients. But then, as we agreed from the start, it will be an interactive session. So I'll be asking questions, picking up people picking up brains to answer. So what do we want to achieve in a spine clinic? Alex, what are our goals doing a spine clinic?
So to identify the correct surgical candidate.
Yeah.
To investigate where necessary.
Yeah. So
yeah.
Thank you. So what I meant is what's the form that we need to reach? Can you see my screen, guys?
Yes.
Okay. So we were saying that we need to be slick. We need to investigate rightly and appropriately and find the right information. And then we need to put them in the right order. Okay. And by that, it makes sense and it makes decision making a lot easier. Okay, so for me as a consultant sitting in a clinic room, and then one of you guys come to my room, say, I want to present a case to you, and then I start listening. So there are certain things in my mind, okay, that certain questions in my mind, right, that I need answers. And if they are answered sequentially in my mind, it makes the decision making so easy. But for example, if you come in and you start talking to about the MRI scan to start with, that doesn't make sense to me. All right, and then the decision making becomes very difficult. But if you go through the sequence that I'm going to go through, all right, then it becomes easier for you and for me, and then the clinic becomes so quick, so enjoyable, and it becomes useful for you guys. I know quite a few of you are planning to do the exam at some point, and the clinic is a very important place to be educated. So I thought I'll just give you an overview of the pathologies that we see in spine clinics. So what do we see in spine clinics? So by the way, there will be some few things in this talk about the FRCS exam, but maybe we will be doing we'll have a session dedicated for spines in FRCS, because of the number of patients that we see in spine clinics. It might not be the best medium like to examine the patient thoroughly, and because we need to do things in a quick fashion. In any way, so what pathologies do we see in the spine clinic? You can see degenerative spine, deformity, and we'll say a few points about infections and tumors at the end of the talk, but it's mainly degenerative, less likely deformity, and less of infections and tumors. When it comes to degenerative, in the cervical spine, it's either a disc or cervical canal stenosis, and in the lumbar spine, similarly, it's either a disc or stenosis. When it comes to deformity, it's either a coronal plane deformity, which is scoliosis, or a sagittal plane deformity, which is kyphosis, or slip of one vertebra on top of the other, which is called spondylolisthesis. All right. And as I said, infections and tumors, we'll say a few words at the end. So if you're going to do a spine clinic, you need to do your red flags. I know there are quite a few registrars and SHOs on this call, and different levels of seniority and knowledge. So for the senior people, you will know most of what I'm going to say, but I've just pitched it at every level so that everyone will gain something out of it. So if you come to a spine clinic without knowing the red flags or asking the right questions to rule out red flags, then that's a liability. All right, because as Alex said, one of the main aims of spine clinic, or maybe the most important aim of spine clinic, is to pick up the dangerous pathologies, the life-threatening pathologies, which are tumors and less likely the infections. Right. The rest, which is like mechanical back pain, prolapse, radicular symptoms, deformities, all of those are not time critical, but tumors in particular are time critical. We need to find out about them in the right time frame. So red flags are, who are there? Let's see. Yuji, can you tell us what are the red flags that you look for in spine clinic?
I guess red flags would fall into two groups, systemic and local red flags. History of trauma is a concerning red flag. Saddle anesthesia is a red flag. Changes in bowel or bladder function. Back pain associated with the known malignancy. Systemic features of things like infection, weight loss, concerning red flags as well, just for instance. Sorry, what was I audible?
Yes, I could hear you really well, but you had a bad effect on Fady.
Can you hear me?
I'm lulled him off to sleep.
Okay. So thoracic pain,
Yes.
So pain in the thoracic spine. Guys, can I ask you to switch off your cameras so that it just reduces the bandwidth a bit? Sorry, I love to see you, but yeah, thank you. So thoracic pain,
Yeah.
particularly pain that is not related to activity. So one of the main things that you should have in mind doing a spine clinic is that pain mechanical or not mechanical, right? For example, if it is related to activities increased by sitting, standing, walking, right? This is mechanical pain. If pain that is not related to activity, I don't sleep at night because of the back pain, all right? This is a non-mechanical pain and they should raise concerns. Number two is the fever and unexplained weight loss, bladder or bowel dysfunction, history of cancer, ill health or the presence of other medical illnesses, progressive neurological deficit, so there is progressive weakness in the legs, for example, disturbed gait, saddle anesthesia. Age is a very important red flag, which Yuji, you didn't mention the age, which is very important. Any patient less than 20 or more than 55, this in itself is a red flag. Does anyone know what are the yellow flags? Yes, thank you, Homa. Thank you. Okay, so this is a clear example how you need to answer in the FRCS. You won't know all the questions, but just have something to say. All right, they are not the red flags. So, yellow flags are a group of social, okay, or psychological factors. You do tend to sense them in the consultation, and they give you an idea that this patient might not be doing well or will not do well, or might you need to consider consulting the psychologist or pain team, because the outcome for surgery in those patients are not the best, shall I say. So yellow flags are a negative attitude that back pain is harmful or potentially severely disabling, fear avoidance behavior, reduced activity levels, an expectation that passive rather than active treatment will be beneficial. They come say, doctor, just do the surgery. I'm not going to do anything. I'm not going to engage in any advice, and so on and so forth. A tendency to depression, low morale, social withdrawal, social or financial problems. So they are not necessarily things, physical signs that you can elicit or things that you can ask about in the history, but you do tend to pick them up mainly with experience. For example, I had a patient who's filing for early retirement and with chronic long-standing back pain. Just have them, they should, a light bulb should light in your head that the patients have more than 1 year of flag. Does that make sense? So what do you, when it comes, for example, to pain, David, how do you ask about pain in a spine clinic? So that just the minimum list of questions that will give you what you need to know.
So where's your pain? How long has it been there? What aggravates your pain, activity or non-activity related? What have you done for the pain so far, and what does it come with? So are there any other symptoms that it has? That's what I'd start with.
Thank you. So how long have you had the pain? Is it 1 month, 6 years, since you were a child? It does make a difference. Where is the pain and where does it go? And on that point, I asked them to point out, okay, not in, I mean, lower back is not an answer to me. All right. So more often than not, they point to one side, right or left. You can actually very vaguely identify the level. Is it mid-thoracic, thoracolumbar, lower lumbar, L4-5 or L5? So where is the pain and where does it go to, and how bad is the pain? For example, we see different patients with different pain thresholds. Okay. Is the pain severe? Is the pain just 2 out of 10? Is it 8 out of 10? Is it really disabling? Is it interfering with activities of daily living? I need to get a taste of how bad the pain is and how is it affecting the lifestyle. Is it related to activity, like what David said? It's very important, again, to stress the point that we need to be experienced on how to identify mechanical from non-mechanical pain. That will make a huge difference. Treatment, as David said, have you had any treatment? Have you had any, so there is a step ladder of pain tablets, and what pain tablets are you taking and what frequency? Have you had any physiotherapy? How many sessions? How long ago? And what is the effect of this treatment? If they say, doctor, I'm on tramadol and naproxen, pain goes completely, then I don't need to interfere. If they say, no, I'm on buprenorphine patches, it doesn't do anything to me, then it's something else. Do you understand what I mean? So you need to know the treatment, and you need to know if they're working or not. So that's pain. There are other things. For example, if you see patient in clinic with lumbar or cervical stenosis, all right, then they complain of claudication. And claudication is like heaviness or burning sensation in the calf whenever they walk. So you need to ask two questions. Number one, how far do you go before you get this burning or heaviness or tightness? Is it I mean, it's difficult to ask patients to say, oh, it's 150 meters, 300 meters, but maybe, can you walk to the corner shop? Can you walk around your property? Can you do your shopping? All right, they say, no, it's only a few steps before I get this heaviness and tightness. The second question would be, what do you do to get on top of this pain? And then they say, oh, I squat down, I sit down for a few minutes. Standing up, if they say, no, I just stand in my place, this is not classic neurogenic claudication. So you need to identify a few steps, few criterias of the claudication, okay? And it makes a lot of difference for me when someone comes to my room and say, oh, this patient has claudication pain, and the claudication distance is few meters, and they have to sit down for about 2 to 3 minutes. That is basically what I'm thinking. This is a critical stenosis. Does that make sense? Myelopathy, okay? If you suspect that the patient has myelopathy, then what questions do you ask? Are you dropping stuff? Okay. What other questions, Alex, do you ask if you think that the patient has myelopathy?
I would ask about progression. I would ask if it's in the hands. I would ask about their walking and their gait, whether they've got loss of balance.
Yeah. So in order to discern if they have problems with their hands, there are a few questions like dropping stuff, buttoning shirt. Are your hands generally clumsy? Did you notice that your handwriting has changed? All of those things are pointing towards deterioration in hand function. But also, as Alex said, are you stable on your feet? And you'll be surprised that patients say, no, I now, every time I step down from the curb or the pavement, I fall. Okay, it's something very new to me, all right? You should be able to pick those terms and then interpret them into probably a spinal cord compression. Deformity. If you sit in my scoliosis clinic, okay, there are a few key questions that you need to ask, mainly about menarche. Okay, if you see a female patient with scoliosis, I need to know the menarche, because decision making is based around her the remaining growth potential, and menarche is one of them. 2, is there a family history? Okay, and then obviously the last thing that you need to ask about is the past medical history. All right, Izzy, what questions do you ask in the past medical history?
We just ask whether they're seeing a GP for anything, whether they're on any medications, any previous surgeries, any other neurological problems.
Yeah, thank you. So basically, the past medical history, the things that are important. So now, if we're thinking that patient might be a candidate for surgery, it does make a huge difference to know if they had coronary heart disease and stenting, and they are on regular antiplatelets or anticoagulants or not, if they had 2 previous strokes, if they had 3 episodes of DVT, one of them progress to a pulmonary embolism. It does make a huge difference. So basically, you ask about any regular medications, any allergies, past history of any heart disease, chest disease, any other disorders, history of surgery. But there is a bit of a social history, so it will make a difference if they to know if they are the primary carers, or do they look after themselves, they live alone, they look after their elderly wife who's ill. Where do they live? They live in a 3rd floor flat, they live in a bungalow, they live in a house. Those things do make a difference in terms of the decision making and post-operative care. And this is also important for FRCS. If you go in to take a history from patient, you need to finish your history by those questions. Do make a difference, because the examiner will immediately know that you have done it before, you sat in clinics before, and you've prepared patients for theatre before. You're asking those questions. They do make a difference when it comes to decision making. If I have a patient with severe right L5 radicular pain, not fit for a haircut, then obviously I will persevere with medical treatment. Does that make sense? Are you with me, guys?
Yep.
Yes.
Fantastic. All right. Any questions so far? Anything to add?
Can I ask a question about the Waddell signs? Are they a very controversial thing, or is that very like a historical thing? Waddell signs, when we think that spinal pathology is, to do with, not to do with physical pathology.
Yes. I don't do them in clinic anymore, but I mean, obviously they can point out if the patient doesn't genuinely have those ridiculous symptoms. Now we rely more on the yellow flags, and from experience, you do pick up that it's probably not genuine, if that makes sense.
Yeah, great, thank you.
Any other questions, guys? Anything to add? I'm more than happy for you to add some points.
Nope, all clear so far, thanks.
I was curious to know what you look for in the social history.
So in the social history, I just want to know if they are if they look after themselves. Are they their primary carers? Do they look after other people or not? Because obviously, if you're going to commit them for example, there is a whole new scope of doing surgeries, deformity correction surgeries on elderly people, right? So I want to know if they are fit and well for that procedure or not. If they are looking after their elderly husband who has stroke 7 years ago, then probably reconsider, because I'm going to take them offline for about 6 weeks or longer. All right. Where do they live? If they live in the 5th floor flat, for example, that means that post-op there will be a lot of occupational therapy challenges, social care packages, and so on, rehousing probably, or something like that. And I had my fingers burned so many times with these stuff where we're stuck with patients in hospital because of that. What else? In the social history, do they do any sports regularly? Because that makes a huge difference in terms of if I have a patient with degenerative scoliosis, all right, they say, oh, I play golf two times a week, for example, then I know that probably I should be thinking that he has something to preserve. So think about surgery a lot more, because if he cannot do his golf, then he would have lost something. Does that make sense? Does that answer your question, Eugene?
Yes, it does. Many thanks.
With
examination wise,
I didn't see spine patients, but I mean until Fady puts me on the rota. But with elderly patients, I tend to ask them 3 questions. Do you do your own shopping, cooking, cleaning? Do you look after anybody else? What other help do you have at home? Because you want to have focused answers rather than a sort of rambling story about their life.
Great, yeah. And again, those questions are important in the exam, guys. In the exam, you need to be slick. You need to know your questions. You have no time to think about them. All right. Right. Examination. So number 1, I look for tender points. So where exactly is it hurting? They might point to this area, and then I try to elicit some tender points. So, okay, he has L4-5 facet joint pain mainly on the right-hand side. Range of motion, have a rough idea. We don't measure in centimeters or anything. Just have a rough idea. Is he flexible? Is he restricted in flexion? Does extension brings along the pain that he feels? Is that a sign? Who else is on the call? Nick, what's the importance of pain coming with arching backwards? Like if I arch if the patient arches his back backward, and it starts to be painful. Is Nick with us?
Is it more common in like spondylolysis or spondylolisthesis? I'm not sure.
So pain on arching backwards is more or less pathognomonic for facet joint arthropathy.
Okay.
All right. Neurological examination. So have in your mind a scheme, which is also helpful in FRCS, because you don't have time to examine the patient, lying him down on table. Maybe you do, but if you're short in time, you should have a scheme, particularly if the patient is mobile, where I'm sure you know it, where they walk on their tiptoes, walk on their heels, and then squat down and up. Then you can very quickly screen for L4, L5, S1, and for the quads as well, which is the upper lumbar nerve roots. All right. Do you know that? I mean, we can show it in a separate video when we come to FRCS. Nerve root stretch signs. David, back to you. What are the nerve root tension signs or stretch signs?
So you have your straight leg raise, and then you'd be commenting on at what angle it's positive on each side, and whether it's equal and symmetrical on both limbs. Conversely, you can do a prone femoral stretch test as well, which looks for the higher roots. These are the 2 I tend to use.
Or have you heard of crossed straight leg raising?
That's a phenomenon where
so biceps, triceps, knee reflexes, ankle flexors, Babinski's.
Yeah, and there is a whole lot of things about, because it's common in the exam to get other still with you. What other reflexes do you do?
So supinator, biceps, triceps.
So those are the deep tendon reflexes. There is a whole entity in cervical spondylotic myelopathy called the pathological reflexes. Does anyone? Have you heard of them, Duncan?
No, I don't know enough about them.
So there is the inverted radial, where you tap the brachioradialis, and then you what happens is that the thumb and the index finger go into flexion. Very important thing in your letters, because obviously, particularly patients who are going for surgery, all the things about Montgomery and so on and so forth. So it's very important, not just in spine, But for any other specialty, and for you guys when you become fellows and consultants later on, it's very important that you document all methods of treatment that you offer to the patient. For example, if you offer injection, all right, and the patient refused it and said, no, absolutely not, I want my decompression, doctor. And then you go on to offer the decompression. It's very important, you mentioned in the letter that you have offered the patient injection. He was adamant he wants to skip this line and go on for the decompression, and in presence of significant compression of the right L5 nerve root, we've agreed to go ahead with the decompression surgery. It's also important to mention all the risks of the procedure that you mentioned to the patient. In this day and age, do not forget to mention that you've told the patient about the risks of catching infections, COVID pneumonia, and so on and so forth, right? Very important for you guys. MRI report, always look at the report. And for any deformity case, just get an AP and lateral whole spine standing views. Do not forget to do that. Questions?
Actually, you know, I remember doing the exam, right? And they showed the AP scoliosis. And I guess one thing to point out is it's not PA film, it's an AP film. So sometimes they can catch you out on that in terms of where the curve goes. Is that right? I vaguely recall something like that in the exam.
So that's a very important point, Swan. Thank you. So all our whole spine scoliosis view are actually PA, not AP.
Yeah.
All right. So you're correct on that. But do you know why?
The spine is closer to. I'm not sure.
Because there's less radiation to the breast.
Exactly, Homa. Exactly. Most of our
radiation to the breast. Okay.
Yes, yes. Most of our SCOLI patients are females. Yeah. So if you do a PA view, you protect the breasts. But you can say PA view. If you want to show off in front of the examiner, you just say, yes, we do PA views because we want less irradiation to the breasts. But the thing is, there will be a mark, a right and left on the whole spine X-ray, and you just put the X-ray. Imagine the X-ray. Is it flipped or not? If it is not flipped, then it's the opposite. So I cross my hands like that. So this is the right side of the X-ray, and this is the left side of the X-ray. If it is not flipped, horizontally flipped. Does that make sense? Is that your question?
Yeah. Thank you.
Any other questions, guys?
Nope, that was great, Fady.
So I do hope that it was beneficial in a sense, and I do hope if you guys want to ask any questions offline, do text me. And more, if you're doing your exam and you want to have some more grilling on examination, I'm more than happy to do that when the clinics come back.
That's great, and we're hoping to get you back, Fady, for an FRCS type session with questions and answers. To do that.
All right. Cool. All right, guys. Thank you very much, Homa, for organizing this session. I'm so glad to see you all guys here, and good luck with. I hope the spine clinics will be less painful, and hopefully in the exam. I mean, the spine scenarios are very few in the exam. I was lucky; I had a spine fracture in the trauma section, and I had a spondylodiscitis in the general viva section, but I don't think they are common. There are very few scenarios, and I'm more than happy to let you know, to give you some buzzwords and keys on how to get the best marks in those scenarios, obviously.
That's brilliant, Fady. Thank you very much.
No worries.
Thanks, Fady.
All right, guys.
Thank you very much.
Take care.
Bye.
Thank you.
Thank you.
Bye.
Bye bye now.